Now we're going to hear from three medical leaders representing different regions of the country, and I am going to be very intimidated by this next discussion, but I'm really looking forward to it. I'm looking forward to hearing about their experiences over the past 5 months and what they've learned about this virus that has upended life as we used to know it. Dr. Carrie Byington is the Executive Vice President of University of California Health. Dr. Paul Rothman is the Dean of the Medical Faculty and the CEO of Johns Hopkins Medicine. And finally, Dr. Selwyn Vickers is Senior Vice President of Medicine and Dean of the University of Alabama School of Medicine. Welcome to all of you. Thank you so much for joining us. Let me ask, Dr. Byington, let me ask, right now, because I know that you are in the middle of research, and I'm interested in, right now, medical college and universities play in almost They play almost every spot. You've been looking at baseball, they're playing shortstop, first base, third base, out behind left. And I'm interested in what's going on in the research scene in finally beginning to look at a vaccine and what your corner of that looks like.
Thank you so much, Steve. As you know, academic health centers are concentrations of excellence in clinical care, research, and education. Our research infrastructure was very well prepared to respond to the COVID-19 pandemic. And we have done everything from evaluating the genome of the virus to preparing clinical trials. So we have been involved in creating laboratory diagnostic testing, in creating new therapeutics for trial, new methods of vaccine delivery, and we're actively involved in the major clinical trials across the United States. So we're very much involved in the research enterprise addressed at ending the COVID-19 pandemic.
And do you, before we jump to Dr. Vickers, is there anything you don't have that you need, or do the resources that you have today fit? I mean, I'm interested, part of the other reason for discussions like this is to talk about the deficits in our resources or how we can be smarter. But are there things that you and your team need that you don't have today?
Our teams are very innovative and very creative. And we have fought supply chain issues throughout the pandemic. We have relied on the ingenuity across our campuses, everything from crafting face coverings from our theater department to our biological laboratories, creating media and transport media. And we have even used our engineering departments to print personal protective equipment, 3D printing of nasal swabs, and ventilator parts. So we do need a robust supply chain, but we are fortunate to have the creative faculty members and students and trainees that allow us to innovate during these difficult times.
Dr. Vickers, one of the things that many Americans began to see was the incredible sacrifices that frontline workers are making in this time of COVID, the dangers that they were subjected to every day, some of the shortages they were facing. Can you share with us, from your perspective of being in a major center in Alabama, about how you look at that, those frontline workers, their training, and the role of medical colleges in helping to instill in them, in a sense, the training and that commitment to save us?
Yeah, I think there were multiple factors. I agree with Carrie in the sense that our faculty, our staff are truly resilient. Sometimes we forget that the first term about this virus we use is novel. And novel meant that for every aspect of what we were doing, it was creating our own roadmaps as we walked. Right? We didn't have drugs initially to treat it. We didn't know all the organs that it damaged. And we didn't know a great deal about its transmissibility and how robust it was. So this was going into a battle not knowing much of the rules and having to create them yourselves. And so most of our academic medical centers created treatment protocols on the fly that they spread throughout the country and throughout their states, because there was no written set of protocols written in any textbook about this virus. It was fortuitous, though. 2 years ago, I announced a large grant we'd gotten in collaboration with other institutions that we were leading on. It was a U-19, and the number one project 2.5 years ago in that grant was development of viral therapeutics for coronaviruses. And I kind of laughed. I said, who cares about coronaviruses? 2 years ago, obviously, it's a different word now, and came out of that the drug remdesivir as a part of our development. So through innovation, through putting themselves at risk, but also having to write the rules as they go, we've had our frontline workers deal with a tremendous amount of stress. And then finally, I would say the biggest emotional stress they've had to deal with is that almost in every other case, when we have a patient, they are often in a very difficult situation or dying with a loved one or a group of loved ones. What we've asked our frontline providers to do is to be caregivers as well as family members and bridges to family members, because these patients died alone. And they were either using FaceTime or on phone calls where they could say their last words to their loved ones. That was immensely stressful, in addition to all the other risks they were facing.
You know, when you think about it, and I don't mean to pressure you, but you think about 170,000 people have died, so many stories going through exactly what you just shared. Is there, before I jump to Dr. Rothman, is there anything that excites you as you're looking at the research that you know out there? I know that you're a specialist in gene therapies and you pay attention to the latest. Are there any bank shots or wins out there from a therapeutic or a vaccine perspective that you can give us some confidence about, or do we just have to wait and see?
You know, I think David said sometimes as scientists, we communicate often through publications, and
right.
That takes time to get out. And many times we don't communicate our successes as quickly. But if you look at the timetable of where we went to understand that the cause of this disease was a virus, and then sequence the virus, and then develop a vaccine, that was unbelievably rapid. Our shortest timeline of developing a vaccine is months, is 4 years. And we're talking about going from a point of identifying a virus, knowing its genome, then manufacturing viruses, not by using dead viruses, but by in really novel molecular techniques, using really the reactive and infective parts of the virus as the sort of the stimulus for antibodies in the vaccine. And we're talking about somewhere in the order of 7 to 8 to 9 months of having a vaccine. God knows, I think we'd have all loved to pull something off the shelf that we could give everybody, but it's pretty amazing. And we still don't have a vaccine for HIV. So for our scientists here at UAB, here at Hopkins and the California system and across the country to participate in that process, and the leaders at the NIH to do so, is quite remarkable, and it's exciting. That excitement, however, is a bit dampened when we understand the tremendous needs in our public health sector, and that this virus took advantage of what may be arguably our greatest strength, the American independence, the American pride, the American singleness of mindedness to do it my own way. This virus took advantage of that strength and made it a weakness, because this is where you need united and conformity more than anything else to beat it. So it's mixed. Our scientific world looking for therapeutics, which I hopefully will come along with the virus. I think that's very exciting. But I also understand that there is a tremendous public health need that sits in the backdrop of that.
Thank you. Dr. Rothman, one of the obsessions that I have, and I'm not very good at it, is where is research going? What is happening with scientific advancement? And I often feel like those of us in the media that are writing this are using frames from 10 years ago, 15 years ago. But when you look, we haven't even had the iPhone that long. We've had, the genetic code decoded. And I'd just love to kind of get from you an understanding of the research terrain, the scientific terrain, and help us understand what should be our North Star in understanding how to talk about R&D in this time and attacking COVID.
Well, if you think about COVID, there are several ways we could possibly attack it. The first one would be to prevent it from infecting the body. And there are several approaches that are happening. Vaccine obviously is the one that we are hoping for. And I think Selwyn said it very well. Our ability to go from sequencing the virus in the early part of 2020 to having phase 3 trials is amazing in the period of time. And there are now probably 180 different vaccines that are being tried. There are other approaches to keeping it from infecting the body. One of those approaches is using antibodies, pre-made antibodies, via monoclonal antibodies or convalescent sera. So we're part of a national trial which uses sera in patients that have had COVID, giving that sera, especially only sera that has antibodies to COVID, to other patients to either help those patients who are already ill or those patients who were just exposed to COVID to see if we can intervene in them getting the disease. The third terrain is therapeutics, and those are mostly antiviral type drugs, and there's several of them. And Desiree is one, but there's several others that are either in trial or coming on trial. And finally, there are other ways to sort of help the body deal with it. Some of that research really was very important, which was understanding who needs to be ventilated and who didn't need to be ventilated. But as we go on with this disease, what people should know is this is a really bad virus. It really affects people. It makes them, the 20% or so who get sick, they get very sick. And what we're starting to learn is it's not just a 2 or 3 week course for many people. They go on for weeks and now months. So understanding the normal disease course is going to be really important. And we and others have using big data sources to try to follow these patients and try to indicate, and I think the most important thing we're trying to do is try to understand who's going to get sick, who's not going to get sick, who's going to get sick for a long period of time, who's going to recover, try to identify them early on and try to intervene in any ways we can.
Thank you so much for that. Let me ask all of you this question, and to some degree, it's going to be a little unfair to Paul Rothman because I've been up to Johns Hopkins a lot. You know, it's nearby, but there are communities in America where there are 20-year disparities in life expectancy, and the greater Baltimore area is one of these. And yet Johns Hopkins, one of the greatest medical centers, research centers in the world, is sitting there. I could say the same thing about all these other centers. And so I'm just interested in Carrie Byington, when we talk about ending the unevenness in health outcomes, reaching vulnerable communities, as Dr. Scortman was just talking about. Are there ways in which you're changing your methodologies to reach communities that were different today than, say, 5 months ago?
Certainly. The University of California has always had a commitment as a land-grant university to serving all Californians and to reaching all Californians. Much of that was done through our own clinical infrastructure, our affiliations. What COVID-19 has done for us is really jumpstart virtual care and the telehealth networks that we've developed. Before the pandemic, we had fewer than 5,000 virtual care visits each month. We're now approaching 200,000 virtual care visits each month across our system. And those virtual care visits include clinics and expertise in critical care. So being able to reach communities where there are no academic health centers and really no hospitals that have previously cared for ventilated patients. We've been able to share our expertise much more widely across the state of California, in New York City, where we worked with individuals during the crisis there, on the Navajo Nation, and across the southern border in Mexico. So through technology and sharing of information, either virtually through telehealth, social media, Zoom, we have created many more connections that I believe will help us to serve more individuals.
That's really exciting to hear about. Dr. Vickers, how are you approaching that in Alabama, which is another of the areas when you kind of look at the impact of COVID right now, and it's now kind of hitting rural communities, there's a different wave. And I'm just sort of interested in how institutions like your own have had to change the game a little. I think we have you muted. Sorry about that.
When it comes to communities of color, you're correct. there's a huge opportunity. And I think this virus has really highlighted the risk of health disparities. COVID-19 has linked lethality to chronic disease more than anything we've seen. We tended to tolerate these things in the populations that were vulnerable, but this virus made it very clear a number of things. Number one, that if we don't take care of the population, everybody still has a chance to do poorly and get infected. But most of all, if we don't, they don't have a chance to often recover. So you see almost a 2x occurrence of death as relates to the population percentage across the country, and that's inclusive of Alabama. Birmingham is 75% African American. And so all the disparities that you see in Baltimore unfortunately exist here. I think the challenge for most of our academic medical centers is that it's hard in this scenario to get in the game of trust building if you hadn't done it already. And I think all the ones on this call have been in the game of building trust with those communities so that they would feel a place where they could get treated. But in spite of that, we found that the communities of color had very disparate beliefs about the virus. Early on, there was a thought that the virus really couldn't infect Black people. And that quickly got dispelled. We had a town hall meeting on Facebook with over 120,000 people with pastors, community leaders. I was fortunate enough to participate, but it was to convey from trusted voices that this virus is real and that it could be lethal. So we've continued with a focus that's increased because we have more resources around it to actually empower and engage those communities for testing, changing the multiple factors. And the final thing I would say, there are a quartet of factors that put those communities at risk, and they're largely around the social determinants of health. Many of them live in high density areas. Many of them are essential workers, meaning that they can't do Zoom from home to do their job. Many of them have to travel in public transportation, which exposes them to higher risk of virus transmission. And many of them suffer from chronic diseases like diabetes, heart failure, kidney disease, and obesity, which even if they're managing it, this virus didn't care. So we've gone back to intervene around these social determinants as well as these medical determinants. And I think, as Paul mentioned, this is not a one-time hit. Even though you may have the virus, there could be chronic problems for a long time. And so we have to look at managing them long-term as well as we intervene to prevent it as well.
Thank you so much for that. And Paul, I'm going to ask you the same question, but I'm going to make it a little tougher. I know Johns Hopkins, I respect it so much. Sometimes we have discussions that are a little bit siloed. We're talking about health, but I know at Johns Hopkins, I think that you're also looking at other factors that contribute to community health and looking at, urban design, looking at, the way, what technology, so that the other pieces, because to some degree, when we look at, the medical provider or the healthcare university, that's almost sort of the end of, not the end of the line, but it's sort of there, but there are these other pieces in the kind of social ecosystem that matter. And I'd love any reflections on that and how that can become a smarter part of what you're doing in research and providing health in Baltimore.
So, Steve, thank you. I'll weave that into the discussion about how we've tried to ensure that all our communities were able to get the care they needed in COVID. Very early on, we set up a private-public partnership between the state of Maryland, the city of Baltimore, ourselves, and the University of Maryland, because we knew that we'd have to tackle this problem in communities that had scarce resources. That partnership has done several things that, Steve, to your point, that have gotten to really address the questions of how we handle this disease in those areas that are underserved. First thing we did, we set up a hospital in our convention center here in Baltimore that can take up to 250 patients. And these are mostly patients who, after their hospitalization, could not go home. They wouldn't have the care they needed to. So this is a place for them to go and recover as an intermediate stage in their disease. We also knew that there were some people who could go home, didn't need that hospital, but needed care, or lived in places where they had multiple people living in a household. So the city helped set up hotels that we've rented out and let patients with COVID stay so we can isolate them away from families. Finally, we knew that testing was a big issue in communities. Testing centers might not be where they are. So we, with the state and University of Maryland, set up testing sites in several underserved areas to ensure that everyone would have access to testing.